An essential shift our county must make to test out our PDSA and eventually achieve success implementing CAN's integrated CFT meetings is to reconceive the way we think about CANs. Like many other jurisdictions, San Francisco has long conceived and utilized the Parade Foundation's CANS tool as a behavioral health tool to screen children for presenting mental health symptoms and to meet medical necessity for Medi-Cal-funded therapeutic interventions. However, Parade Foundation actually designed and envisioned CANS to do much more than assess mental health concerns. CANS is a process intended to inform assessment, case planning, service planning, and monitoring. CANS is evolving from our current use by behavioral health as a mental health tool to a process utilized by the child and family team to have a common language to talk about and prioritize case planning around the SOP behavioral needs and strengths of each family member based on how they impact the safety, stability, and functional well-being of the family. The CANS tool features 7 domains: behavioral emotional needs, life functioning, risk behaviors, cultural factors, strengths, potentially adverse childhood experiences, and caregiver resources and needs. The CANS is supposed to be scored for the child and all caregivers in the past 30 days, including the parents and the substitute caregiver. San Francisco's current CANS application involves having clinicians interview or observe children. Clinicians also routinely interview the caregiver, generally the resource family, and sometimes they interview the parents to score the different CANS domains. Sometimes clinicians will complete a CANS screening and present findings that the child is fine, that there are no needs or recommendations. What the clinician is presenting is that the child had no scores indicating that the child's presenting behaviors met medical necessity for mental health therapies. However, the completed CANS screening did not consider the parent's caregiver resources and needs, or how the parent's outstanding needs and/or lack of mitigating resources brought the family to the attention of child welfare. All cases involved with child welfare by design are involved precisely due to concerns about the primary caregiver's unmet needs or lack of resources that impacted their ability to safely parent and meet the child's needs. CANS as a behavioral health tool centers on the domains about the child's presentation. CANS as a process to identify child and family strengths and needs to case plan also focuses on the parents' and caregivers' needs and resources to be able to care for the child. In our county's current application of CANS, only the child's presenting mental health concerns are considered, not the child's holistic well-being in the context of the family. A baby may be doing well and have no physical, emotional, or developmental concerns in the care of a resource family, but the birth parents may have unaddressed needs. They may be struggling with mental health, substance use, supervision, knowledge gaps, be uninvolved with care, lack social support, have medical, developmental, or physical limitations affecting their ability to provide care, or maybe they have residential instability. All of these issues could impact their ability to safely care for and meet the baby's needs. In the reconceptualization of CANS and how to use the tool, we look at the child and family in context of how the family functions together, the child as well as the parents. CANS is evolving from a tool presently used to screen mental health symptoms to a process that will assist safety, permanency, and well-being needs for each member of the child's household in order to identify what needs and strengths for each individual must be prioritized and changed for the family to function safely together. Per current child welfare policy, SDM Family and Child Strengths and Needs Assessments must be completed prior to development and updates of the case plan. Think about the information used to score the Family and Child Strengths and Needs Assessment. Who participates in scoring the strengths and needs to evaluate what needs will be prioritized for case planning? Oftentimes, a PSW makes the assessment alone based on the PSW's own observations and interviews. San Francisco's current use of CANS has the clinician as the lone expert who meets with the child, caregiver, and sometimes the parent and decides on the scores. The clinician then participates in a facilitated behavioral health CFT that is designed to be a small, intimate meeting at which the clinician shares CANS findings with the parents and protective services worker, hears the parent's perspective and addresses any questions. CANS information is considered private mental health information protected by HIPAA. CANS integrated CFT meetings change who provides and collects the information about the child and family's strengths and needs, and how the needs and strengths will be prioritized for case planning and service planning. Praed Foundation actually intended CANS to be a communimetric tool to be used by a team versus a tool scored alone by a clinician as protected mental health information under HIPAA. Communi means group and metric means measure. Child-adolescent needs and strengths are to be informed by, discussed, and evaluated together by the family's team versus a single clinician. The clinician will still complete interviews and score a preliminary CANS tool, but the CANS will not be finalized until input is incorporated from the family's own selected child and family team. The idea is to have individuals who the child and family trust, who really know the family, share their observations, knowledge, and examples of family functioning to obtain a more accurate perspective and baseline of what family functioning really looks like. Prior to the meeting with their self-selected team, the child and family are asked to determine with whom they are willing to share information about their substance use, mental health, and sexual and reproductive health. Clients age 12 and older and their parents will be asked to give general consent to proceed with the CFT meeting. The clinician will still participate in the communimetric CANS process, but the clinician role will evolve to be the CANS consultant and recorder who writes down the scores versus the behavioral health expert on the family. The clinician listens to the team but does not share personal family information or violate HIPAA. The clinician may ask clarifying questions of the team to get a more thorough picture of the child and family's functioning. The assessment process is owned by the family's team. The family and the team are the experts who share observations and examples of the family members' functioning. They ask questions and rigorously discuss the degree to which intervention is required to address a need. The team uses everyday regular language to discuss safety needs that require immediate interventions, needs that must be addressed long-term in case planning, and other issues that will need to be watched and may require future intervention. They may also identify centerpiece strengths that the child and family currently use to support the safety and well-being, strengths the family sometimes uses to address safety and well-being, and resources or strengths to which they have access but don't routinely use to address their safety and well-being. SOP strategies such as the 3 questions, what are we worried about, what is working well, and what needs to happen next, are used to explore and identify the specific behavioral needs and strengths of the 7 CANS domains. For example, a clinician may identify worries about a child's social and developmental functioning based on observations of the child's mute response and interviews with a new caregiver in whose home the child has been just a few days. The expanded child and family team is invited to share stories and observations about what works well and what the worries are concerning the child's social and developmental functioning. Family friends and school personnel help flesh out what the child's behavior looked like on an everyday basis prior to her separation from her parents and her home. Behavior originally observed in the foster home and scored by people new to the child may be recontextualized as trauma response versus social or developmental worries. The team may identify the child's interpersonal relationships, educational focus, and supports as centerpiece strengths to address the worries and strategize how to maintain the child in her school of origin with supportive contact with close friends and mentors to support her well-being during her transition in foster care. Perhaps the child came into care due to the parent's intimate partner violence and neglect of the child's care. Through the use of the CANS process and SOP strategies, the child and family team may share worries about how the parent's intimate partner violence impacts the child and how the parent's care actually looks on a day-to-day basis. The team helps articulate what safe parental interaction, supervision, and involvement with the child's care will need to look like for the child to be safe with the parent. Behavioral objectives and goals for the parents are defined by the team discussion. SOP worries and wells and CANS needs and strengths ratings indicate the level of intervention or action required. CANS has 4 level scores of 0, 1, 2, and 3, where 0 is considered optimal and no intervention is necessary to address a behavior. An SOP safety threat is similar to a CANS need that is dangerous or disabling and requires immediate intervention. CANS would score the need as a 3. SOP worries that impact functioning and require case planning are equivalent to CANS needs that are not dangerous or disabling but still require intervention. These behavioral needs would be scored as a 2. SOP worries about behaviors that increase risk to functioning may be complicating factors. These behaviors include significant history of behaviors or needs that are concerning but do not currently interfere with functioning. These are behaviors that the team would want to watch and possibly take preventive measures so they don't escalate and require intervention. They would be rated as 1s. A teen may have no SOP concerns about substance abuse for a teen who has never used drugs. CANS would indicate no evidence of a need in this area and would score a 0, indicating no action is needed. If the youth actively volunteers for a peer group against substance use, this might be a centerpiece strength that the team could use to address other identified needs. Centerpiece strengths are also optimal and scored as 0. Perhaps the team is worried that the teen was caught smoking weed at school and was suspended last year, but is not known to have smoked recently, and her everyday functioning, schoolwork, and relationships remain unaffected. The CANS score may be a 1, indicating no intervention is presently required, but the team should continue to watch the behavior and prevention work may be helpful. The teen's interest in participating on the school basketball team that requires good grades, no drugs, and regular school attendance may rate a 1 and be a useful strength to motivate the teen to abstain from weed. If SOP worries are raised about the youth cutting school to smoke weed, this is a behavior interfering with her current functioning and school attendance. CANS would score a 2. Intervention and case planning is required to address the youth's behavior. The youth's interpersonal relationship with a teacher who mentors other students at the school may be a strength to develop and also rate a 2. An SOP worry about a youth using drugs and passing out, necessitating medical attention, is a safety threat and dangerous, disabling need that requires immediate intervention for safety. CANS would score a 3. On the CANS strength domain, if the youth is isolated, has no natural supports, and is disconnected from community life, a 3 may be scored for this strength, indicating this is an area needing lots of development. During the CFT meeting, the worries and wells identified and discussed by the Child and Family team are translated into CANS scores by the clinician. They provide an easy way to assess, chart, and measure what behaviors need to be addressed, what strengths can be built on, what level of intervention is required, and whether progress in addressing the behavior has been made over time. Take the example of a 3-year-old who was living with his mother. The child was found wandering alone on the street after he crawled out his bedroom window after his mother left him without supervision. Within the CFT meeting, participants may identify what is working well, including the interest and availability of the child's extended family, who is occasionally supported and cared for the child. The clinician will listen to the discussion and may ask clarifying questions to determine the relative's current role as natural supports, providing some care to the child, perhaps a score of 1, or whether the relatives are available and display interest but need to be developed as a source of support for the child, perhaps a rating of 2. What level of support do the natural supports presently provide, and what level can they provide? Could they be developed as relative caregivers or as ongoing support for the child and family? Worries identified by CFT participants will include the reason the child was brought into foster care, the mother's lack of supervision that led to a 3-year-old climbing out a window unattended is a safety threat requiring immediate intervention and would score a 3. Mom's substance abuse and lack of knowledge about a 3-year-old's developmental needs and the safety issues of leaving a 3-year-old child home alone may be scored as 2s or needs requiring case planning intervention over the course of the case. The child's emergent crying and anxiety about being left alone may also be scored as 2s and require intervention to help him cope with his trauma. Father may have been uninvolved with the child until the child welfare case. His involvement with the child may also be scored as a 2, requiring intervention to address his ability to care and provide for his child. All of the worries and wells about the child and family functioning are captured by the clinician as baseline behavioral scores and objectively recorded on the CANS. Meanwhile, using the family's own wording and language, the CFT facilitator writes the child and family's behavioral goals identified by the team on the action plan known in San Francisco as the Shared Family Care Plan. An outline of the strategies and next steps the team commits to take to support the child and family to reach their goals is also written on the plan. CANS provides an objective record of the child and family assessment and intervention level required. The Shared Family Care Plan captures family-specific behavioral goals to address the worries and what intervention strategy shall be adopted and followed by the family and their team. With CANS integrated CFTs, CANS focus shifts from service planning to case planning. San Francisco currently uses the CANS screening to determine if the child meets medical necessity and to make recommendations for specific service interventions such as individual therapy, parent-child interactive therapy, therapeutic visitation, dyadic, or family therapy. CANS integrated CFT meetings will shift the focus on service planning to case planning, monitoring, and transition. Services may still be recommended and identified as part of the CANS process, but they are a small part of the larger CANS CFT case planning process. Child and family teaming strives to engage families by encouraging them to bring together people who they trust, who really know the family, to develop and participate in a support plan that will actually work for the family. The team will identify safety threats or needs requiring immediate intervention. Some members of the team will become part of the safety plan for the family. The team will identify other worries about the child and parent's family functioning that require intervention over the course of the case. They will help identify strengths to bolster the family, and they will help the family set behavioral change goals for the case plan that promote family safety, permanency, and well-being. The child and family also provide moral, emotional, and tangible support to help the child and family achieve their established goals. County policy requires CFT meetings be held every 90 days to monitor progress toward case plan goals. The child and family team reconvene with the PSW and the behavioral health clinician to update the entire team about the child and family's progress. The clinician brings the baseline CANS tool for which he finalizes scores after integrating the input of team members at the original CANS CFT meeting. The child and family team review the last action plan goals per the Shared Family Care Plan they developed at the last meeting. The facilitator will guide the team using SOP questions, worries, and wells to reflect on how the plan went. What does the child's and parents' behavior look like now? What were the parents and their team's follow-through on tasks and commitments that they made? What is the team worried about now, and what is working well? During the discussion, the CANS clinician will take note of the team's observations and perspectives of the child and family and will rescore the CANS tool to chart the progress the family and child have made toward achieving the behavioral goals that the team identified at the last meeting, as well as any new behavioral goals. The team will prioritize the child and family's most current pressing safety and well-being needs. The case plan and behavioral objectives may stay the same as originally identified, or they may change based on what the family has accomplished since the last check-in and what is currently happening in their lives. The team helps adapt the case plan and strategies to support the family to achieve their behavioral change goals. As the family makes progress toward completing their behavioral change goals, the team continues to work together using the CANS discussion process to identify how to support the family after child welfare is no longer involved. In cases in which parents are no longer involved with the child, CANS is still informed by the child's child and family team and is used by the team to case plan around the child's needs. For example, parental supervision and care needs for an abandoned child may prompt goals of permanency and action steps to address concurrent planning. A young person transitioning to adulthood without parents may need case planning to address a supportive transition to independence and permanency connections. Or a youth and juvenile probation being raised by a relative may need case planning and support to stabilize mental health, stay in school, and achieve a stable home environment. Think of the CANS tool like quarterly progress reports used in grade schools with identifiable skills to master and scores indicating the family's progress. Every 90 days, the CANS Integrated CFT meeting regathers all the team members who support the child and family in mastering the goals. These quarterly CFT meetings help hold the family accountable for their behavior and also hold team members accountable to their commitment to support the family. The child and family team do not give up or blame the family. If progress on the child and family's behavioral change goals has been achieved in some behavioral domains but not in others, the team will reflect, analyze, and work with the family. They will practice with them, cheer them on, and when necessary, adjust the strategic plan with the family in hopes of finding a strategy that works for them.